So welcome everyone, and we are really excited to get our 2025 year started. And this is our first Hub Advisory large group meeting for the year. For others that may not know, we have been meeting actually since 2019, every other month, and we have now grown to about 90 plus organizations that are taking part in this work, coming to the table to talk about bringing health and social care closer together, bridging that gap, and seeing what wonderful things that we can do when we do it together. And so starting off, not going to take too much more time here. I'll go ahead into presentation mode. And hopefully I'm looking at Lisa here when that shows up. Does that look good, Lisa? All right. All right, so we have a lot of good things to share this today, and again, a lot of number of different programs going on. But here we're going to go ahead and showcase a couple of them, and hopefully set up some vision for what we want to do with technology, and therefore engaging maybe some more of you in some of that work. So you've seen our agenda that I shared earlier. Again, not going to spend too much time here going through that because I do want to give our organizations presenters here a chance to share what they need to share, and then hopefully maybe have discussion time at the end. So if Julie, if you are ready, I want to introduce Julie Rash, the Chief Operating Officer at Primary Healthcare. We are excited for her to share today about a project we will be initiating very shortly. And I'm not sure, Julie, if you need to share your screen or if this works okay for you.
It might be, yeah, I can share what I have. That way people have something to look at instead of just my face talking at people. So I will share real quick here. That viewable for everybody? Yes? Okay, sounds good. So we've been partners with the Hub for quite a long time. Dr. Barry Ingebretson is on the call as well. And so he led primary healthcare on this path with the Hub, which has been fantastic, and lots of growth and just making things better for our patients. So again, I'm Julie Rash. I'm with Primary Healthcare. We are a federally qualified health center here in central Iowa, serving communities in the Des Moines, Marshalltown, and Ames regions. And we have the opportunity to apply for, it's called a design sprint with our National Association for Community Health Centers. And it was the perfect opportunity to tie in the work we were doing with the Hub, and specifically with our patients who have degenerative joint disease. So we applied for the design sprint, and what they were really looking for was an organization that wanted to do project implementation, process improvement, and the project had to involve social driver of health and a community partnership. So it was perfect. We already have something going and we need to keep building and making it better. So we have one sprint team, so one primary care provider care team, and then our partner with the Iowa Hub on the project. And we really designed it around what we were already doing. We had started down the path doing the degenerative joint disease of the hip and knee, and trying to work on how we assess for pain and activity limitations, how social factors might impact the activities that patients can do and just their daily living. And then the key or the goal was just refer those patients to the Hub. If they qualified for activity as an intervention for their condition, then let's refer them to the Hub, and the Hub can take the baton and run with it to get those patients connected to the right resources that were affordable, and something the patient was interested in. So we've gotten that far. We've chosen this project. The CDC actually funded the Iowa Arthritis Project in conjunction with the National Association of Chronic Disease, who I believe is speaking next. And so we already had this project established, and felt like the sprint would really be a useful way to keep trying to implement and make it better. So the location we're choosing for the sprint is in our Ames clinic. We've already identified 194 patients that have an existing diagnosis. And then our provider, Lachelle Good, is one of our nurse practitioners there, and she actually has 75 of those patients. And we learned that buy-in, of course, is super important, and so she was very interested in the project along with our nurse care manager in that location. So they are our small and mighty team to give this a try. And so we'll, of course, use other resources as well just to make sure that things go smoothly. But the design sprint is really meant for just 4 people on our side and 4 people from the hub to participate. And so they've got it all laid out for us. They're going to do some workshops, a couple hour workshops, and then we do virtual office sessions where we're trying things and testing things out. Some of the things we've already put into place just with the previous work that Dr. E got going with the arthritis project. We worked to get our Epic workflows ready to go, figuring out which assessments for arthritis needed to be in the office visit, the pre-visit planning tool, so how we plan for those patients before they come in. And then we're fairly new to Epic. We're a year and a half in, so we're still learning a lot, but we were able to find that arthritis best practice advisory that fires for the provider, so they know, when they're eligible for certain things and how to place orders. So next steps, I would say we're really working on better team buy-in, communication, more training, and then just evaluation of the process. So we're hoping the sprint helps to guide us on that path. And then, of course, referring patients to the hub. That's our big outcome, is the number of patients we identify as qualified for activity as an intervention, and then how well are we doing getting those folks to the hub. And then, of course, the measure for hub is probably how many of those patients engage and connect to the activity intervention. So yeah, we're excited to get going, and that kicks off next month. And you're on mute, Trina.
Thank you so much. Still
Yeah.
doing that. So thank you. Yeah, no, thank you so much for that summary. I'd like to just open it up now for anyone that might have some questions. I know we have other healthcare providers and partners here on the call. If they have any questions about, what we're working on here together and setting up and testing. We've got some work, again, like you heard from Mary Greeley, with diabetes prevention program. We've got some work with University of Iowa with falls prevention, and there's others. So hopefully, if anybody has any questions for Julie, and Dr. E is also on the call, if that, yeah, just opening that time now for that questioning. Yes, Jimmy.
Good morning, everyone. Good to see you, Julie. Hi, Dr. Ingebretson. Thank you so much for sharing all of that oversight. Quick question. In terms of adoption for your team, can you perhaps share any words of wisdom on any type of facilitators or any barriers? I know that there's so many moving pieces at the clinic level. So I wonder, from your providers, from your staff, if there's anything that you could help us. So if there were anything that any barriers identified or facilitators that could help expedite the process and embrace the adoption, because as you know, something new, something innovative, sometimes it takes a little time to adopt, but I wonder if you can just elaborate a little bit on that, if you could.
Sure. I think part of the barrier for us this past year, we started this in one of our other clinics with a much larger group. We kind of started with a larger scope, and I think just the understanding of the why, what we were doing, and really meeting purposefully with that group ahead of time is very important. And so it feels really tiny to start with just one provider in one clinic. But I know if we can see success in that and find your champions that are interested, I kind of, what do I want to say, cast the net to our medical directors, which providers might be interested, had a few one-on-one conversations, and looked at the data, of course, to see that, okay, do we have a good population to start with? And then just a really strong champion that's interested. If you don't have interest, you're not going to go too far. It's going to be a lot of pulling. So hopefully she has interest, and hopefully that stands true, and we don't get derailed with other competing priorities, because that's always another challenge.
Thank you so much.
Yep.
Well, Julie, Trina, you've probably mentioned this already. This is Greg. So I think when you said Ames location, that perked my ears because obviously we have a lot of us from ISU are right here local. And we actually have pretty strong connections with McFarland already. And so it's nice to hear also Mary Greeley is involved with the DPP. So, but we've had there's a BPA already built in, and we've been working with them on our knee osteoarthritis, but we've had some challenges with that the BPA isn't triggering until unless a person comes in with that specific problem. So we'd love to work with you on that, and we have the other connections to the folks at McFarland that can maybe help. So I think a number of us from the U-Turn team could play a role and help.
Sounds good.
That'll be great, Greg, for sure. And then we'll hear more too in a moment, but from Lisa on kind of the whole project and a little bit of those challenges and things to look for in the near future. But so one of those, Greg, is we'll be tackling together that BPA kind of fatigue that some people bring up, or if it's valuable, if it's helpful, if it's not, if it's a deterrent, things like that we can be evaluating and looking at.
They've definitely expressed that. So.
Anyone else? All right. Well, fabulous. Thank you so much, Julie, for sharing. We're really excited to partner with you in this work, and which leads into Lisa's presentation a little bit to share kind of the background. So again, what Julie was referring to with the Iowa Arthritis Project, Lisa now is going to go into that in a few minutes here, and that'll give some background to, again, then taking it to this and adding this new design sprint project that we're doing with Julie and her team, and Dr. E. We're really excited about that, and hopefully that will continue to refine this process. So Lisa, just like to introduce you really quickly. She is with the National Association of Chronic Disease Directors, in which they are a critical partner in our Iowa Hub efforts, as they are to many other states. And Lisa's expertise and leadership has truly helped us drive impactful health initiatives across Iowa. So I'm going to give her a chance now to take it away and share a little bit about this Arthritis Care Project. And please, if arthritis is not your a specialty or of your interest, please think about this as laying the groundwork and framework for other initiatives, other chronic disease, and other needs in the community that we can be setting up a similar type system and process. Thanks, Lisa.
Great. Thanks, Trina. Thanks so much for having me. As Trina mentioned, I'm Lisa Irk, and I want to take a minute to let you know a little bit about our team. I'm joined today by my colleague, Heather Murphy, who is my right-hand gal on all things arthritis. We also are joined by Ali Jaglowski from the Center for Advancing Healthy Communities. And sadly, our fearless leader, Julia Shevin, is not here today, but she would normally be the front and center face for this arthritis work. And she has just done a tremendous amount of very valuable work so far in this. So I just wanted to take a minute to recognize our team and to thank everyone for their hard work. Trina, are you seeing my screen and the slide in terms of the framework? Great. So as Trina mentioned, we have been really excited to partner with not only the Iowa Community Care Hub, but several health systems and arthritis partners, Dr. Welk and his team and others. And this funding is made possible from CDC, and our team is really working to support states and community-based organizations in their efforts to work with healthcare providers, not only on arthritis management, but really on physical activity, focusing on pain, physical function, that quality of life for adults who certainly have arthritis, but also those, as Trina mentioned, who have other comorbidities or other chronic pain conditions that are limiting their physical function. And so we've been tasked with developing an arthritis care model. And this is really a public health framework for collaborative arthritis management and well-being. And I'm going to walk you through briefly this framework so that you can understand exactly what we're doing. But this piggybacks really nicely on Julie's presentation.
Do we want to continue to work with them?
I'm sorry for that background noise. What we are doing is really looking at how do we understand various different components that feed into the Arthritis Community Care Hub partnership. And so we're starting specifically with the idea of screening. And we have several tools that have been identified from our partners and from our expert panel as being important in this process. So the first step is to really ensure that we have a proper diagnosis for OA, and really using that screening protocol, including the physical activity vital signs and PROMIS measures to identify physical activity levels and to triage patients based upon pain and physical function. So that's the first key element of our arthritis framework. And then we move into this concept of brief advice. And this is the idea of really triaging those patients to understand the why, to understand the importance of physical activity and pain management, but also to really do a very brief risk assessment to triage those patients towards the community care hub and to identify how we can accurately meet their needs and really continue to meet them where they are to triage them towards those best solutions. And that is then what takes us to that referral process. And so in this beautiful partnership with Iowa, that referral, as I just mentioned, is to the Iowa Community Care Hub, because as you all know, they are a valuable partner and resource. And that's truly a testament because this group continues to grow every single time I'm on the call. There are more partners, more health systems, more amazing faces to see. And that truly talks to the importance of the Community Care Hub in this model. And so we are referring those patients to sometimes PT or OT, other times to specialty care, but most times to the Iowa Community Care Hub or other community care hubs to really do that one-on-one identification. And so you see as we move in, this is where, of course, you get the social determinants of health screening that we know is so valuable to the work of the hub. The hub navigators are going to engage those patients in shared decision-making on the appropriate intervention or arthritis appropriate intervention in this case that will really address their physical activity needs, their pain and physical function. Those are what we refer to as these arthritis appropriate evidence-based interventions. These are programs that have been deemed appropriate for patients with arthritis, but they are also applicable to others beyond arthritis and focus on things like Walk with Ease, chronic disease self-management, Tai Chi for arthritis, many programs that are in the field and in the community that can be paired with programs like the National Diabetes Prevention Program to holistically address the needs of the patients. And then the idea is that the individual participants go in, get enrolled in the arthritis appropriate evidence-based intervention or the appropriate evidence-based intervention that meets their needs. They complete those sessions. We are tracking outcomes. We are giving a bi-directional feedback loop back to the healthcare provider and the Iowa Community Care Hub and those patient navigators so that we have constant referral and constant feedback on what's working with the patient, how that's impacting health outcomes, and where they're going to go in this triage process. And so because of this pilot in the case of Iowa, we are partnering with the Iowa Community Care Hub and primary healthcare, as you heard earlier in the sprint design process. So this pairs really beautifully with that sprint design process because we are truly able to move forward towards implementation. So I want to briefly go into help you understand why did we select Iowa. And obviously I could go on for hours and hours about why we selected Iowa because truly, as you all know, because you live and breathe this work, you all are fantastic partners. But this is really important for us to understand as we move towards scale and spread. So we selected Iowa because they had the right people. They had the right partners. They had the right relationships in the community with this diverse group of individuals here today and beyond. They also had capacity. They were hungry. They had interest. They had champions. They had commitment at all levels of different organizational structures. They have strong leadership and governance. The hub has the ability to truly take this and run with it and embed it within their practices and protocols. They have the knowledge about the business case. They have relationships with health systems and partners. Not only are they focused on health and health outcome, but they're also focused on community drivers, social determinants of health, health equity, making sure that our programs are truly relevant to all patients, regardless of where they live, work, and play. They also had an understanding and key partners who could really understand the data aspect and the importance of informatics and truly having that bi-directional feedback loop. So our team has been working hard to not only pick the right partner. We've done that, but also to document those qualities, because those will be really important as we scale and spread to other health systems in Iowa and ultimately other states that we work with at NACDD and beyond. We also, of course, not only have the beautiful partnership with the Hub, but we also had a partnership that was in place with primary health care. And that partnership was brought in well before NACDD. Trina and her team had already established those relationships, had already been doing referral work within primary health care. So it made a natural step for us to move forward and build on that strong partnership between the Community Care Hub and primary health care. Thanks, of course, to the leadership and the strong support network from Dr. E, from Julie, from others from the care team. And so I want to briefly walk you through what have we been doing. We are in year 4 of a 5-year cooperative agreement. But in this first year of partnership work, which really started in our year 3 and has moved into year 4. So about the last year, we've been working hard to identify those clinical champions and the key players who would be part of this team from the Iowa Community Care Hub and from primary health care. We also focused on building that infrastructure. So those are things like the best practice alert that has been formed, the triage for the patient specifically, understanding the Epic build. As Julie mentioned, Epic is a relatively new system for PHC within the last year and a half. So really understanding how this could be embedded within Epic, not only specifically within the health system arena, within the federally qualified health system purview, but ultimately we hope beyond for others who are using Epic, which, as you all know, is a large player in this space. We really wanted to make sure that we had the agreements in place so that we could share data back with our evaluation team at Dartmouth and beyond. We also then spent some time making sure that we truly understood that we had the appropriate infrastructure in place within primary healthcare to do this work. So we established, of course, the protocol within the electronic health record, but we also worked with Joy and her team and others to look at workflows and to ensure that this is moving within the health system arena, that we have the appropriate tools and resources to facilitate this change. While working on, of course, that infrastructure, both within the Community Care Hub and the health system arena, we also noticed that we needed to do some trainings for clinicians. So that training is ongoing. We have built out a learning management system and modules specifically for the clinicians and the champions and members of the care team within the hub. We are also taking those trainings and developing additional supporting tools and resources to ensure that our partners have what they need to make those referrals and to truly understand the importance of partnering with the Community Care Hub. And that first year also culminated with a very valuable site visit where our entire team came to Iowa and met with many individuals on this call in person to not only show our face, but really to truly understand the work that you're doing and to provide that face-to-face opportunity for connection and collaboration. And that was truly, I would say, one of the strongest aspects of our first year and really an exciting piece of our visit. And this is just a photo, of course, to show you the importance of that in-person setting. You, of course, see Trina here. You also see Izzy, who has been very, very instrumental in all of this hard work. And we absolutely would not be here if it wasn't for her drive and passion and vision. So some of the insights that would be relevant, Jimmy just asked the same question before of Julie, kind of what are some key factors that we see in this partnership moving forward and how are we going to translate that? So I would first start off by saying a champion is really important, but the S at the end of champions is even more valuable. So those are champions within multiple stages of the organization and in different roles within the community. And those individuals need to have different touch points and skills. And that has been very clear from the beginning of our pilot. We also needed to understand how things were working on a day-to-day basis. So what did workflow look like before we came in? And how could we build in on the infrastructure and protocols in place? And what tools were needed to really facilitate that change? We also wanted to ensure that we understood what data was already being collected and captured, what tools and screening protocols and beyond were part of the health system, and how could we leverage that within our work. We also wanted to make sure that one of the biggest insights was truly emphasizing the role of the Community Care Hub and how this partnership is very valuable for other states and other organizations. We also really understood and are starting to continue to understand the role of technology and the complex aspects that technology plays in this workflow, and how that facilitates that referral process, and how we need to leverage technology, but also in some cases how technology is a barrier to the work that we're trying to do. We also would recommend really understanding what the white noise in the background, kind of the other priorities that clinicians are facing, the truly in the weeds aspect of what is going on within this work, and then trying to figure out how our work can fit into those competing priorities, and really understanding that importance. That really has been very clear in this work and beyond. Again, I'm going to move into the idea of training clinicians and clinical staff and using multiple modes to ensure that we are properly meeting their needs and making sure that they understand the work that we're trying to do. And last but not least, I already emphasized this, but we truly believe that having an on-site site visit is very valuable to truly understand the work that is going on. And then I just want to end with, I feel like everyone always talks about reimbursement and billing codes and how we're going to get this work. And that is very important to this work, but it may not always have as significant as a role for every population as we once thought it did in this process. And so that's been a big lesson learned in this work and being patient throughout the process. So really quickly, what comes next? We're expanding to other sites. Within PHC, we're capitalizing on this sprint project and really using that as a way to move some of the work forward. We're going to continue to revise and refine based on the Plan, Do, Study, Act cycle, and really using the data to inform where we go and scale and spread. We are also planning to continue to partner with the Arthritis Champion, Dr. Welk and his team, who are funded to do this work. And we will continue to build on that partnership and expand to other clinics that they're working with. And we have several health systems on the call today that are partners with the hub. So I envision at some point it would make sense to continue to expand this beyond PHC to other partners that already have strong relationships or are building strong relationships with the hub. And then, of course, we'll go beyond Iowa. There are 12 states, 11 including 12 total, 11 plus Iowa, that are doing this work that are funded by CDC. And so they're in our balcony, if you will. They're learning from this work. They're learning from your leadership. And we will continue to take the lessons learned from this pilot and beyond and share it to other states that are doing it and replicate it and grow with other partners. We already are in the process of working with North Carolina with a PT clinic from Duke, and that is part of our scale and spread. And that will be a very different dynamic than the primary care arena that we're partnering specifically with primary health care. So we're going to continue to do these presentations. We're going to continue to publish. We're going to continue to develop tools and resources on the importance of Community Care Hub. And I just thank you, Trina, for having us today. And I will end with that. And thank you all for your hard work and all the work that you do.
Excellent. Thank you so much, Lisa. That was super comprehensive, and hopefully it gave everybody a really good visual and understanding of the project that we're working on with primary healthcare, with NACDD, but also the bigger picture of how we can take what we learn here in this project with to other partners in the state. And really, this has been a great focus in on if you look at our Community Hub diagram nationally, they always put on the left-hand side of a diagram of a community hub where the community care hub's in the middle. On the left side, they always put our healthcare system partners with the referrals into the hub. And then on the right-hand side, they share with all the CBOs, not just the program providers, but many of you here today, the resource for social care resources in our community on the right side. So right now we focused in on that left side development with the pathways, creating the processes and the partnerships to be better at identifying patients, screening for their needs and getting them connected then eventually to the right-hand side, which we've got lots of work and more to come in future meetings. But Joy, I'm going to have you introduce our next speaker and presenter. And this is kind of a really good segue into it because Lisa shared about technology and how technology is super important And so Joy, if you want to go ahead and take a moment to introduce Evelyn, that would be great.
Yeah, so it's my pleasure to introduce you to Evelyn, who leads EMI Advisors. At a really big focus of connecting healthcare and social care is around data standards and interoperability, a lot of what Lisa alluded to, and Evelyn's certainly an expert in this area. So I'll let her talk about some of the visioning we hope to bring to Iowa. Evelyn?
Thank you so much, Joy, and good morning, everyone. Again, thank you, Trina, for the opportunity to join you all today to talk. And I love that. Yes, perfect segue, the role of technology and visualization. So I'm happy to quickly go through. I know there's a lot of slides here, so I'll preface that these, Trina, you may share with everyone. These are open slides to give a sense of what we do. I may go quickly through some just because, in particular, the case studies, because these are really there as examples of what we've done in the past, so you can think through of how that can apply with your work in Iowa. So just quickly, and can you all see my slides? Make sure. Yeah, great. Okay, so just a quick introduction about who we are at EMI Advisors and what we do, and then examples so you can actually see how we've applied our approaches at a national level and a state level. So you can get a sense. So who we are. So I'm the CEO of EMI Advisors, been working in data interoperability for 2 decades. Our work is very much embedded on really harnessing the power of technology, right, for good. So we are located out of the Washington, D.C. area. I'm Canadian, so Trina and I share that. I originally hail from Canada. My parents are from Colombia, South America. But our team is very passionate about what we do. And as stated here, we really work across the sector. So primarily working on health and human services, and do a lot of work with the Department of Navy, the defense side. And most recently, we've been scaling our work at the federal level. So primarily, we do have supported as a certified small business, federal health and defense agencies. And most recently, we've been scaling our work to help state agencies and community-based organizations really think through of how they can apply what happens, these policy drivers and new technology to help them address their problems across, individual community societies and our planet. So gives us a sense of who we serve. We've worked across the gamut, again, primarily federal agencies, but we've worked with a lot of academics. Lovely to see, Sync Health. We worked with Sync Health, and that's how I met Joy. We've worked with a lot of health information exchanges and CIEs. So it's it gives us that sense of how all these organizations can come together to solve problems collectively. Our core capabilities are within these 4 areas. So again, I'm not to go through all of these, but really I'd say the premise of what we do is human-centered systems thinking. And we didn't used to call it that. I think now it's just we've been doing it and didn't realize that we were just combining these frameworks, and really have seen the ability to solve problems collectively by bringing stakeholders together, but being able to zoom in and zoom out. So this is really where we say we need to put that human lens. So it's not looking, the work that we do is solving across really intricate and siloed systems. As we think of health, public health, and social care, they have not, not for until the last decade, as we've talked about, advancing around social care integration. These really organizations and ecosystems have existed in silo, and now we've had the opportunity to bring them together, but it's still big problems to solve. And a lot of other work we do where we know the systems thinking applies is when we think of climate and the impact of climate changes on individuals. So really, when we think of environment, where it's not driven by social needs, is like, how do we bring that together? Our other work, data analytics and decision intelligence, is really how do we bring that data together and visualize it for problem solving, policy alignment, and program strategy. That's personally my area of background, really looking at how we bring together policy, national, federal, state level, and really helping it use that to be able to define better programs, but also evaluate whether the programs are designed correctly and the policies need to be changed. And of course, are really around solutions. So digital and enterprise solutions is thinking through of our understanding of what tools exist in the market, what are the capabilities that they need to be able to perform. So a lot of our work is being able to advise in those areas. We say about bridging the gap. Often we talk about connecting the dots, but I love to see, you know, I think there was a visual too around being able to be that bridge, right? And when we think through of technology, there's so much happening right now. And as we think of the plethora of new generative AI tools and a lot of discussion around artificial intelligence, what does that mean? And we actually created this before the digital transformation, as we say, but it applies, right? Because we're really talking about how do you leverage this technology and the investments to what is of value for the organization and the stakeholders you serve. So how do we do that for community care hubs? I love to see all the diversity of stakeholders on this call today. It really it encompasses what we do as we bring these different viewpoints together. And our examples I'll talk through our case studies is where we've had the opportunity to really help bridge and connect and create the right organizational structure that allows an open and transparent and a safe space for having these diverse entities and stakeholder groups together. And also of importance is always keeping the person, the individual, and their caregivers at the center. Often we've seen that on the health side, very, I would say, health-centric or medicalized is really where you bring all the providers together, the health plans, the policymakers, and you're not bringing in the individuals, the patients, and ensure that their lived-in experience is incorporated in any new policy or program that you work on. So it's really about supporting this, what we call the participatory co-design approach to solve problems collectively. And I'll show how we do that. And just lastly is how we can help. So this is really just highlighting a high level. We do a lot of things within EMI and we try to bridge everything and collectively and make it cohesive because we don't do everything, but we want to be really focused, laser focused when we come in and we support. So we say we were able to look at market intelligence. We do that a lot. A lot of this work is what even we do as part of our technical assistance that been able to work with Joy on our CDC work. And Trina has also been part of our technical assistance with the Administration of Community Living when we were providing support, bringing all the state agencies together and community-based organizations as part of their learning collaborative that we hosted last year. But so it's around market intelligence, strategic planning, operational readiness. That's really important as we talk through about digital transformation. Do you have the capacity needed? And I love seeing that from Lisa's presentation, that really the strength of the Iowa Community Care Hub is they've spent a lot of time, a lot of focused effort to ensure that you're building the capacity for the services you want to provide. And that often ends up being the primary drivers. Are you set up for success? Policy impact analysis, I talked through in the consensus building, which is really important to have a neutral convener involved. And a lot of that is what we've done. So I'm going to bring us just quickly through case studies so you can see how we've applied that, but also think through of what success has looked like for other organizations. So for those not familiar with the Gravity Project, I heard codes and the screening. EMI founded the Gravity Project, co-founded it with the University of California, San Francisco Siren Social Interventions Research and Evaluation Network in 2018. Since initiation, we've been able to bring diverse stakeholder groups. Over 2,000 individuals now participate in the Gravity Project. Gravity is a public collaborative that develops the national standards to represent and exchange social risk factors and social or health-related social needs. The names have changed since initiation, but we have it's really about collecting and creating common language for this data. And now those codes have been incorporated in national policy So the screening tools and what's required for certified health information technology, payment models, quality measures. So it's come a long way, but part of this is saying that we didn't do this in silo, right? The success of the Gravity Project is really centered about bringing these diverse stakeholder groups together and ensuring we had the right governance structure for buy-in. So Gravity here, as I said, developing data standards. To date, there's 22 domains, really looking across the workflow, screening, assessment, goal setting, treatment and interventions, and incorporates standards to support not only patient care, care coordination, but really around population health. And now, as we're saying, we're doing more around quality measurement and research. So again, we have a common language. I'll skip through this, our work streams, just highlighting, again, bringing why you're all together. Governance I cannot emphasize the importance of having the right structure in place and the right groups coming together. So Gravity the success was really because, as you'll see on the right-hand side, we didn't start this work without thinking through of who was our target audience, but also who else needed to come to the table to ensure the success and champion this work, right? So we looked at across 6 overall stakeholder groups, patients, of course, consumers, providers. We looked across both health and social care, health plans, payers, the vendors, technology needs to come to the table. So great. And I think I'm seeing all of these, except the federal part, as part of your group here today. But this is really important, and everyone coming together, everyone knowing what their role is and being able to contribute to the output, which on the Gravity side are the work stream. It's developing of the data standards, the new terminology, and the implementation guides. And I know this is okay. Just also want to make sure I am speaking. Oh, thank you, Joy. Okay, so success factors, because we establish ourselves bringing all the stakeholders to the table, including those with lived experience. So we had, I won't say technical expert panels, but really our public collaborative allowed anyone could participate because it was open and transparent. But we also were able to have one-on-one and ensure that everyone felt they had a place to contribute. The outcome of that was that we were able to influence policy, national policy, and now we see it also state level policy. The standards are incorporated in payment models and programs, other standards work and grants. I mentioned the ACL work because ACL purposely incorporated in their social care referral challenge funding for entities to apply and create solutions that were tied to the standards. Where we need to do more work and we see evolving is around the practice and innovation level, right? So we need to see how these standards can support repeatable processes. And this is great to have the community care hubs evolve to really show how does this fit into practice and what is the value and innovation. So what too, part of this, like what new tools, what technologies need to come that's advance this around aggregating this data, analyzing and making sure it's being used for impactful change and improving person outcomes. So another case study is at the state level. So for those not familiar, California released a very big law in 2021 where they passed legislation to create the data exchange framework that requires across the state, regardless of program, regardless of payment, is that all stakeholders must come together across health and human services and exchange data. So as part of this, again, they also convened a stakeholder advisory group. How would this be? How do we implement this? They established health at the state level. They established a data sharing agreement as the single data sharing agreement and common set of policies that govern and require exchange. Again, this is with health and human service providers, including several community care hubs. They were all required to come together and start sharing by last year, January 2024. Community care hubs, human services that did not have the capacity were given another year. So they just are rolling out at the end of this month. So the problem to solve, EMI came in as they rolled this out. So they were required last year of January, but by October, we were approached because the state had seen that there was not much traction. California has has many health information organizations, or HIEs, and CIE and community care hubs. So there's a lot of intermediaries, as we call them, and they weren't coming together. So the problem to solve is, how do we really support them in being able to work collectively? So many of them are competitors, but really ensuring that they see this as their common good, and really ensuring that there is value of them seeing how they collect and exchange data amongst themselves while protecting it. So, although there was many connections, so there was a lack of understanding of the value of this data exchange. There was challenges, and continue to be, with integrating information. Every health information organization and their respective partners were exchanging data differently. Of course, legal concerns, consent comes up all the time, and costs, right? So there's costs associated with how you collect and exchange data. So they brought us in together. So how did we solve this? We applied human-centered systems thinking. So, and really, for those not familiar, and there's links here, it's really around how do you zoom in and zoom out of these problems? Zoom out is a systems level. What does the system look across across California? How do these all entities work together? What are the drivers? But then thinking through of how, from a human-centered, is zooming in. What are those individual experiences? What do you want to bring to the table? How do we ensure that how one provider, as we talked about burden, we have an example, we worked with one very large community care hub in California. They had to think through the burden of their staff, right? Of being able to log in to multiple platforms to receive a referral. What does that, how does that look? How does that impact that workflow? So again, very diverse, very complex state to work across. But we applied that. So the solution was, first we looked at it twofold. How do we define the problem collectively through a co-design and community design approach? And then what tool do we create to visualize the problem? So we were brought in and we launched to develop a sandbox. And what we found was that to bring everyone together, each HIO, or now they're called Qualified Health Information Organizations, they didn't want to share they didn't want everyone to come and log in. They needed a common place where they could play around and, as we say, tinker and really visualize how best can we exchange data. So the sandbox is that place that allows real world testing. So the data exchange framework has specific requirements, has different use cases across clinical care, chronic disease management, public health. So they have, so there's ways that they need to be able to adopt and validate and test what is being required by the state. So the sandbox serves as that point. And the community design studios, where we come in and we look at specific use cases by exchanging entities. And that's been very successful. We've had several use cases. So we'll go through quickly what they are. So just background on the sandbox, the business case for it, it's really a regulatory sandbox, but it's a data visualization tool. And I'll go through, these are just everyone's involved. We've had multiple early adopters and supporters. Right now we have active 207 users, lots of, so you have to register. Every entity that Exchange collects data is, they're not required to register, but they have, because they see in value of being able to visualize things. So upfront, the sandbox technical architecture won't go into the weeds of this, but it's really looking through of all the stakeholders you see on the left-hand side. So not only are they HIEs and CIEs or hubs, there's national networks. There's also other networks that exist, and then all the different provider entities. And this is really where we just visualize, this is what language do you speak and how do you want to translate it, right? And that allows, even doing at that level, which we may think is a very simple process, getting visibility of how one entity sends data and wants to receive data is actually a very powerful approach. So it ends up, again, getting that buy-in, bringing everyone together. So the sandbox, this is what it looks like when you log in. The use cases right now that are available and everyone can visualize is emergency department transition, category around aging. So this is really how you send event notifications, which ended up being the primary problem they needed to solve. They weren't being able to, there's no consistent way to send alerts across California. So we worked on that one. Then we completed a housing referral one, and also enhanced care management, referral and care coordination, where we worked with a community care hub. What does it look like? So this is just a use case simulation, which again gets the buy-in when we sort of start showing. These are network visualization approaches where you see what is the entity involved, you show how the data is exchanged. So this is what data visualization looks like, and it's very precise. It's location specific. This is synthetic data, so it's not real world data, but even getting to this part was I would say it was a game changer for those entities involved. And this just goes through, brings in direct. So it, again, very technical, but it allows those technical players and those that have to make decisions around what technology to adopt to understand the art of possible. This is our data repository, what it looks like. This is the location. So it's the sandbox gives you a sense of all the entities participating across the state, and then you could zone in each one and see how they collect and who they currently exchange and are partnered with. Node visualization of all health information exchanges across the state. So here they're listed. This is visualization of all connected participants, and so forth. So this is what data visualization looks like. And I'll stop there. I know we got 2 minutes left. Thank you, Joy. Back to you, Trina.
Yes, you have interest in learning more. There's a lot of different projects across the state that we're working on. Would love to engage you. And so thank you again for your time and for your work that you're doing in Iowa. And have a great weekend, I guess. Thanks, guys. Thank you to our presenters.